the topic of discussion that we are going to have right now is we are going to talk about Parkinsonism. So okay, Parkinsonism, and what are the things that we are going to discuss right here in this lecture. We are going to cover all these points, right? All these points. Now without delay, let's begin with our discussion. Okay, now talking about Parkinsonism. What is Parkinsonism? It is related disorder, right? It is characterized by what? It is characterized by various characteristics, and the three triad are bradykinesia, tremors, rigidity, and other clinical features that are seen during the time of Parkinsonism is what? These are it. We'll go after some time. So what is this? This is slow progressive neurodegenerative disease, right? It results from degeneration of dopaminergic neuron. What we are saying degeneration of dopaminergic neuron in substantia nigra. Now what is this substantia nigra? Substantia nigra, what is this? This is our substantia nigra. It is our subthalamus, this is our thalamus. These are what? These are the part of our basal ganglia. So here this substantia nigra, what is this? This is our what? This is dark colored dark colored substance, and it is due to what? Due to melanin. So what happens is that in this substantia nigra, what will happen is that they will produce what? They will produce dopamine. What they will produce? Dopamine, right? Dopamine. Now this dopamine, right, it is neurotransmitter, and it is for what? It is for nigrostriatal pathway. What is this pathway? This is nigrostriatal pathway, right? What is this? This is it is calling, what we are calling it? We are calling it nigro. Why? Because it is producing melanin, and that's black in color. That's why. So this substantia nigra, what it will do is it will produce dopamine, and this dopamine is for what? This dopamine is for nigrostriatal pathway, and this nigrostriatal pathway from this nigro to this stratum, right? So what will happen is that if there will be no production, if there will be damaging of what? Our this dopaminergic neuron, or if there will be less production of dopamine, then what will happen? This pathway will be cancelled, right? There will be no nigrostriatal pathway, and that will what? That will lead to Parkinson's disease. So what we are saying here is it results from degeneration of dopaminergic neuron in substantia nigra. We have already seen substantia nigra. And what are the characteristics of our Parkinsonism? It is memorized as what? Our this acronym only. What is this? P for pill rolling tumor, from A acanthasia, that is inability to sit still, R rigidity, cogwheel rigidity, K kinesia, that is akinesia and bradykinesia, and from I we have got instability, right? That is stop posture. From N we have got no arm swinging in rhythm with leg, right? And that is, and another is our siluria. What is the siluria? It is some kind of our skin skin disorder. And from this AO we have got oculogyric crisis, that is IR held fixed for variable length of time, that means tolonu, right? We call it tolonu in Nepali. And that from N we have got nervous depression. From I we have got involuntary tremor, that is resting tremor. And from S we have got sevoria, right? Sorry, I just told that siluria is what? The skin disorder, but this sevoria is our skin disorder. Similarly from M we have got marked facial expression, and this can be remembered from this diagram. It is the same representation, right? The same thing is shown right here. Pin rolling tumor, stopped posture, marks like blank expression, right? Okay, it happens gradually after the age of 50. Bradykinesia, depression, muscle rigidity, tremors, shuffling, propulsive gait. Okay, these are the characteristics of person suffering from Parkinsonism. So now, as we have already said, that it is because of the degeneration of dopaminergic neuron. Okay, now in our body to what? In our body there is a balanced level of our what? Dopamine and acetylcholine, right? So they balance each other. They are in opposite what? They are opposite to each other, so they balance each other, and that's why what? There is a normal condition in body. But what happens in the case of Parkinsonism is that the level of dopamine will decrease, such as it will be 50. Now as it will be 50, now what will happen? There will not be what? The normal function. That means the acetylcholine is leading ahead. So this is the condition of what? Parkinsonism. So in this condition, what we can do? We can either, right? We can either increase the level of dopamine, or we can decrease the level of acetylcholine. So to treat Parkinsonism, what we can do? The first thing is we can increase dopamine level, and second thing is we can decrease acetylcholine level, right? Okay, so now let's talk about what? Let's talk about its classification. So there are two types of drugs. One is the one that will increase dopamine level, and another is our anticholinergic drugs, or the one that will decrease our acetylcholine level. Okay, now talking about the one that will increase what? Our this dopamine level. So in order to increase dopamine, we need to know how it is produced. Okay, now how it is produced? okay, there is our tyrosine, it will get inside, and with the help of tyrosine hydroxylase it will be converted into dopa. This dopa will be converted into dopamine with the help of dopa decarboxylase, and this dopamine will be placed inside vessels. From this vessel it is released in synapse, right, in synaptic vessels. So okay, now this dopamine, what it will happen, now they will go and act on their receptor, right, their receptor, and some of them will be what, they will be degraded with the help of this MAO and COMT. So now what is this MAO and COMT? MAO, it is what, monoamine oxidase, and COMT is catechol orthomethyl transferase. So okay, that means now here through these process, right, through these steps, we can just, how we can increase our dopa, right, dopamine, how we can increase the dopamine in order to treat Parkinsonism. The first thing is what, we can give what, dopa ourselves, right, dopa from outside. Another thing is we can what, we can enhance the release of dopamine into synaptic vessels, right, into synapse. Another thing is that we will prevent its what, degradation, right, will prevent its degradation. Another is will provide directly the dopa what, dopa agonist. Okay, now okay, now as I have already said that one thing is that we can give dopa directly, but the fact is that we cannot give dopa directly because it will not cross blood brain barrier, because this dopamine should be increased inside our brain, and what we are doing, we are giving drug into veins, right, intravenously. So what will happen is that these dopa that will give in our blood, they will not reach brain because of blood brain barrier. So what we'll do is we will give L-dopa, right, we'll give L-dopa. And okay, the first drug, right, that we need to know here is, okay, yes, we are talking about drug acting on dopaminergic system, or the one that will help us to increase this dopamine level. The first one is dopamine precursor, that is levodopa, right, levodopa. Here we cannot give dopa because it cannot cross blood brain barrier, so we are giving levodopa. And another thing is that we are going to give peripheral decarboxylase inhibitor, carbidopa and benserizide. So okay, let's go into it. Okay, as we have said that we will give levodopa, what will be, we'll give levodopa. So this is our peripheral blood vessels, right, peripheral blood vessel. As you can see, this blue color, what is this blue color? This blue color is our brain, right, and this brain is covered by what, this brain is covered by our this red colored blood vessels. What are these? These are astrocytes and endothelium of blood vessels. What are these? These are, so we are saying that this blue color, it is our brain, and it is covered by what, it is covered by our blood brain barrier. So as you can see, the blood brain barrier is not completely surrounding what, our brain, right, there are some of these spaces that are not surrounded by blood brain barrier. Now what are these spaces called? These are called circumventricular space. Why circumventricular space? Because they are present around ventricles, right, we know ventricle, third ventricle, fourth ventricle, right, lateral ventricles, yes. Okay, now as we have said that we are providing what, levodopa. As we are providing levodopa, this levodopa should enter into what, our this brain, right, by crossing our this blood brain barrier. So what will happen is that this, when we are providing, okay, let's suppose we are providing 100% of levodopa. Now when we are providing this 100% of levodopa, what will happen is that only 2% of levodopa will be what, it will be reaching our brain. That means 95 to 98% of our this levodopa, they will be converted into dopamine peripherally. That means there is dopa decarboxylase in our peripheral circulation also. So what is going on? We need to increase dopamine in brain, inside brain, but the dopamine level is being increased peripherally, right, peripherally. Now this dopamine, it cannot enter what, blood brain barrier, so there is no use of this dopamine in periphery. Instead, this dopamine, it will have what, it will have several receptors, right, it will peripherally, it will have several receptors such as D1, okay, such as you can see right here, D1 receptor, B1 receptor, alpha 1 receptor, right. Now this, when it will act into D1 receptor, it will cause hypotension, and in B1, these are found in heart, it will cause what, arrhythmia. Similarly alpha 1, it will cause hypertension. And CTJs, as you can see among this circumventricular space, one it is what, CTZ, that is the center for vomiting. So and when it act on CTZ, it will cause what, vomiting. So what we can see is that the levodopa that we are providing is not entering into brain completely, right, it is converting into what, our dopamine outside brain with the help of this peripheral dopa decarboxylase. So what we need to do is that the another class of drug that we need to discuss is that we need to inhibit this peripheral dopa decarboxylase, so that every dopa that will enter into our brain and will get converted into dopamine, so that we can improve the condition of Parkinsonism. So another class of drug that we are going to discuss is peripheral decarboxylase inhibitor, and that is carbidopa and benserizide. So carbidopa and benserizide. So what will these carbidopa and benserizide do? This carbidopa and benserizide, they will inhibit what? Peripheral dopa decarboxylase, right? Peripheral dopa decarboxylase. So okay, now one important factor that we need to know right here is our vitamin B6, that is pyridoxine. Pyridoxine is cofactor of this dopa decarboxylase. So when the person is given this our carbidopa, when the person is given carbidopa and benserizide, at that time we need to avoid vitamin B6 or pyridoxine, because this vitamin B6 or pyridoxine, it is cofactor of this cofactor of dopa decarboxylase. So when we give vitamin B6 along with carbidopa and benserizide, at that time what will happen is that the efficacy of our this carbidopa and benserizide will be decreased because of our vitamin B6. So we should not give it together. So okay, now here one thing that I would like to mention right here is, okay, so now what we are doing, we are inhibiting this thing, and we are just sending our this levodopa, maximum levodopa into our brain. It is getting converted into dopamine. So if we excessively increase dopamine, such as, let's say, at the time what we said that the dopamine is 50 and acetylcholine 100. What will happen if there will be 500 of our this dopamine and only 100 of our acetylcholine? At the time, this condition is called our psychosis. That means psychosis is because of because of excessive dopamine inside our brain, right? Okay, that means what we can say is that if we use excessive levodopa, okay, let's say we use excessive levodopa with with carbidopa or benserizide, then what will happen? There will be excessive amount of dopamine into our brain, right? Let's suppose there will be 500 dopamine inside our brain and only 100 is our acetylcholine. So what will happen at this condition? At this condition, we can say that it is the condition of psychosis, right? Psychosis. So we can, one conclusion that we can make is that all anti-Parkinsonism drug such as levodopa, carbidopa, benserizide, what they will do, all anti-Parkinsonism drug, if used excessively, they can cause they can cause psychosis. And reverse is also the true, all antipsychotic drug can cause Parkinsonism also. Okay, now as I have already said that if the peripheral, right, if dopamine is present peripherally, then what will happen? There can be a lot of side effects, right? Side effects. But these side effects, right, these are peripheral side effect, and there can be also psychosis, that is central side effect, because of because of excessive dopamine inside the brain. And there can be dyskinesia also, and that is also the central side effect. So these central side effects like dyskinesia, right, kinesia and psychosis, they cannot be prevented by this carbidopa and benserizide, which are the inhibitor of peripheral dopa decarboxylase. Because this carbidopa and benserizide, they are simply helping these levodopa to enter inside the brain without letting this peripheral dopamine to be formed, right? If it will not be formed, there will be not these symptoms, right? These side effect will not be seen. But there can be increase in dopamine inside the brain, right? If there will be increase in dopamine inside the brain, there can be psychosis, there can be dyskinesia also. So this is what it is. So now moving further, I would like to mention about one thing, and that is on-off phenomenon. Now what is this on-off phenomenon, right? On-off phenomenon, okay, I would like to make you clear about one thing. Okay, this is our dopaminergic neuron, this is our dopaminergic neuron, this is our dopaminergic neuron, these are our dopaminergic neuron. So when we give levodopa with carbidopa, okay, let's say when we give levodopa, what will happen is that this levodopa will be stored, right, in these neurons, right? Let's say in these neurons in vessels. So the half life, right, now what will happen is that These stored levodopa, what will happen is that first 1 to 2 hour this will be released, right? This levodopa will release, right? It will release, and another 1 to 2 hours it will be released. Okay, like this the like this what will happen is that the levodopa which is given, that will control the symptom for how many, 20 to 22 hours, right? 20 to 22 hours. So this is the normal condition. That means it is being stored and then it is being used what, successively. So now as we know that what the Parkinsonism is, what it is, neuron dopaminergic neuron degenerative disease. So what will happen is that slowly and gradually these neuron that are storing the levodopa will be what, they will be slowly wearing off, right? As they will wear off, what will happen is that the levodopa that we will give will not be stored in what, the sufficient vessels, so that it will be what, it will be directly be released into what, our peripheral circulation. As large amount of levodopa will be released, what will happen is that there will be what, there will be large amount of dopamine inside our brain, right, which can cause psychosis. That means initially, right, when the Parkinsonism is not in that worst condition, at the time what was going on, the levodopa was being stored in different vessels, right? Slowly and gradually they were coming out, and they were what, they were working for 20 to 22 hours, right? But what will happen, but what will happen with the time, what will happen, these vessels will get what, wear off. As a result, the levodopa that we were giving, right, it will be directly released into blood circulation, and as it will be released into this peripheral circulation, it will be sent into what, brain directly, and there will be excessive dopamine release. That means excessive dopamine is being released. That means what is this? This is the condition of psychosis. Okay, now this the condition in which the drug is excessively working, right? The drug is causing what, the drug is performing overwork, or there is large amount of release of dopamine inside our brain, and that is what, that is our psychosis. And this condition is called what, this condition is called our on period. What is this? This is our on period. Now what about off period? Now as we have mentioned that the levodopa which was given is directly being used, right? It is directly being sent. That means as the levodopa is directly being sent, it will be directly sent into what, brain, and there will be large amount of dopamine, and it is leading to what, psychosis. Now within short period of time this will be finished, right? As it will be finished, there is no other levodopa provided, right? At the time, the initial period, there were vessels that were slowly gradually providing it, but now what, the dopamine after 1 to 2 hours, right, there will be what, shortage of dopamine, right? Shortage of dopamine, because all the dopamine is directly used right here. So after 1 to 2 hours there will be shortage of dopamine. That will cause what, that will cause Parkinsonism. Now this Parkinsonism condition, it is called off period. That means on period is the condition in which there is what, excessive dopamine production inside our brain, and that is what, psychosis. And off period is the condition in which that dopamine is now what, the consumed, right? It is consumed, and there is what, lacking of dopamine inside our brain, and that will lead to Parkinsonism. So here you can see on off phenomenon. In late Parkinsonism, when we give levodopa, it controls symptom for 20 to 22 hours. Yes, we have said that a lot of vessels, right, first 1 to 2 hours, and then it will be released, it will work for 1 to 2 hours, then 1 to 2 hours, see, and as so, and this sequence follows, and it will, what is going on, it was working for 20 to 22 hours. But now after that what will happen, wearing off occurs. That means the vessels, the storing vessels will be what, they will be weared off, leading to appearance of symptom, right? Now appearance of symptom means what, this is called wearing off phenomenon, right? Wearing off phenomenon. In extreme cases what will happen, the on off phenomenon occurs. Now what is this on off phenomenon? During on period, what, the excess dopamine level lead to psychosis, and during off period, lack of dopamine leads to appearance of what, Parkinsonism symptom. That's all. So till now what we were talking, about dopamine precursor levodopa and peripheral decarboxylase inhibitor carbidopa and benserazide. Now let's talk about what, our what, another class of drug, and that is MAO inhibitor, right? Now MAO inhibitor, what was this MAO doing? It was what, it was degrading our dopamine into free radical, right? And if you know, the free radical are responsible for destruction and degradation of neurons. So till now the levodopa and what carbidopa and benserizide, what they were doing, they were simply treating the symptom. That means they were not doing anything to to the cause that was causing degeneration of what our dopaminergic neuron. That means the one I mean there may be certain factor that was causing what, then that was causing this degeneration of dopaminergic neuron, right? This levodopa and carbidopa, they were not doing anything to to correct this degeneration of dopaminergic neuron. But here you can see what is this MAO doing, right? MAO, it was it was degrading this dopamine into free radical, right, into free radical, and these free radical were responsible for destruction and degeneration of neurons. So that means the above one that we mentioned were what, they were just for just for getting relief from symptom, but here the main cause, we are going to treat the main cause. So this MAO inhibitor, what is going on here is that we are providing MAOB inhibitor, right? Now since I mentioned B, so there are two MAO inhibitor, that are MAOA and MAOB. So this MAOA, it is present in all places, it metabolize all substance. Now what are these all substance and these all what our this all substance? The all substance is that there can be endogenous substance such as adrenaline, non-adrenaline, dopamine, right? Exogenous substance like pethidine and tyramine. So this metabolize all substance. But MAOB, what is this is present only in brain, right? And it metabolizes dopamine, right? Dopamine. And if you remember what we are going to select, we are going to select MAOA inhibitor or MAOB inhibitor. So obviously we are going to select MAOB inhibitor because it is present in brain and it metabolizes dopamine only, that's all. So now, so what we are going to select, we are going to select MAOB inhibitor, right? So we are selecting MAOB inhibitor. Now this MAOB inhibitor, what are the drugs that we need to know right here? These are selegiline, rasagiline and sulfonamide, right? Sulfonamide. So now these are also used in on-off phenomenon, right, to correct on-off phenomenon. So similarly, now as we mentioned about MAO inhibitor, let's talk about COMT inhibitor. Now COMT inhibitor that we need to know is, we need to know about what, we need to know about entacapone, right? Entacapone and tolcapone. Now this entacapone, it is preferred, but this tolcapone, it is not used nowadays because it is what, it is toxic to liver, right? It is toxic to liver, so that's why. So now next drug that we need to know here is, yes, we talked about we talked about the factor that we are going to save dopamine from its degradation, right? Okay, now moving further, yes, the one that we're acting where, the one that we're acting right here, right, in this receptor, that means dopamine what, agonist, right? Dopamine agonist. Talking about dopamine agonist, what, these are ergot and non-ergot type, and from in ergot we have bromocriptone and in and pergolide. Similarly in non-ergot we have pramipexole and we have ropenerol, right? And these pramipexole and ropenerol, these are safest and these are long acting rather than these. And talking about what, the side effects such as gangrene and fibrosis, these are seen in our this ergot, bromocriptine and pergolide, but these are not seen in what, our this pramipexole and ropenerol, right? These are not seen right here. So drug of choice for Parkinsonism is our what, pramipexole and ropenerol, but the most effective drug for Parkinsonism is our levodopa and carbidopa. So the thing that we need to know here is, these are the most what, the effective drug. These two are different things, the drug of choice and the most effective drug, these are two different things. Similarly, the drug of choice for drug induced Parkinsonism is our benzhexol. Now what is this benzhexol, we will learn in anticholinergic system, right? Okay, now moving further, what we have is, okay, till now what we studied about what, okay, we studied about, okay, the first thing is we completed about these things, the dopa, right, the thing that increases dopa. Similarly we talked about what, we talked about these dopa agonist, right? We talked about MAO and COMT inhibitors. Now let's talk about what these the things that will help us to what release this dopamine into synapse, right? Okay, now let's talk about what are these are what these are our what amantadine, right? Amantadine. Now what they will do is they will act by releasing dopamine from vesicles, right? Also used for as antiviral drugs for influenza viruses. So we can say what are the antiviral drugs that are used in anti-Parkinsonism, that are our amantadine. Now talking about side effects, the popular side effects are our ankle edema, these are reversible, and we have levodo reticularis, these are pinkish pigmentation of skin in form of meshwork. That's all. Now yes, we talked about we talked about all these things. The one is, first is dopamine precursor, similarly peripheral decarboxylase inhibitor, carbidopa and benzodiazide. We talked about dopaminergic agonist, right? We talked about what these are our pramipexole, bromocriptine and ropinirole, right? We talked about dopaminergic agonist. What are these? Pramipexole, these are non-ergot, right? Similarly, we talked about MAOB inhibitor, sedagilin, rasagiline. We talked about COMT inhibitor, these are entacapone, tolacapone. We talked about dopamine facilitator that will help us to release dopamine from vesicles, that are what amantadine. So similarly, let's talk about what now drug acting on cholinergic system, that means anticholinergic. Now what are these? These are what drug of choice for drug induced Parkinsonism, right? It includes benzhexol, right? These are trihexyphenylidene, right? These are benztropine, these are bipyridine, these are procyclidine, right? Similarly, the first generation antihistaminic drug can be also used because they can cross blood-brain barrier, has anticholinergic activity, such as what promethazine, right? Used as alternative to benzhexol in treating drug-induced Parkinsonism. Yes, we mentioned about these things earlier. Drug of choice for Parkinsonism, that is pramipexole and ropinirole. What are these? These are what? These are our dopamine agonists. These are non-ergot, right? Pramipexole and ropinirole. Okay. And similar, these are the drug of choice, but most effective drug for Parkinsonism is our levodopa and carbidopa. Similarly, drug induced what Parkinsonism, it is treated by benhexol, right? Benhexol, that is what trihexyphenylidene, right? Phenyldil. Okay, these are what? These are anticholinergic drugs. So this is all about what? This is all about our Parkinsonism. So I hope we are clear on this topic. Thank you and have a great time.